as we get going, I will do my best to project until we get a microphone. But if you can't hear me, please let me know, and I'll try to do better. So I want to thank Matt and everybody from Nami, Montana for inviting us to speak and provide some additional information not only about the Certified Community Behavioral Health Clinic model, but also the experience of Western Montana Mental Health Center as we move to implement this model of care in Montana. Our transition into this model of care started in 2019. It started with three very simple questions. Are we doing the best we can to support our clients in their recovery? And if not, what does better look like? And what are the actionable steps we need to take to get to better? That precipitated a couple different actions, which started with our mission statement. We felt very strongly that for Western Montana Mental Health Center, as is the case with many other organizations, our North Star, our guiding point, is our mission statement. And for those of you who may have known Western Montana Mental Health Center previously, our old mission statement started with, "We offer." And I didn't like that because it's very passive. And I felt like we needed to be proactive. And as you just heard Matt say, if we want to fix the system, it was our responsibility to step in and figure out how to fix the system. And we need a lot of support in doing that. But as clinical experts, we knew it was our responsibility to define what better looked like and then go achieve it. So you can see in our new mission statement, we take action. We build thriving communities through compassionate, whole person, expert care. And then our vision statement is very aspirational. We want to be and strive to be the premier community provider, employer, and partner in comprehensive behavioral health services. So although that is subtle changes to language, I hope you see that it's a pretty significant change in how we approach the care that we deliver to our communities. All right, is that better?
Yes.
All right, okay. Great, thanks, Mary. So even though our journey to improvement in integrated care started in 2019, it's important to understand the history of the organization. We were originally chartered in 1971. So we've been around for 50 years providing care to various communities in Montana. We're one of the largest providers of comprehensive behavioral health services. And I think it's important to recognize what comprehensive really means. It means we have many, many programs that strive to support individuals who are experiencing crisis, experiencing mental health emergencies, who need support on a daily basis, who need support in their homes. You all understand this, and unfortunately, a lot of folks outside of the NAMI community, outside of behavioral health, don't necessarily understand the complexity of what we do on a daily basis. We're currently serving 17 counties in our primary service area in Montana and have roughly 400 employees. One of the reasons I put this on the slide is that through the workforce shortage, we're operating at about a 20% vacancy rate. So we should have 500 employees. We're about 100 employees short. So that has a huge impact on our ability to help folks. Our primary goal is to create a continuum of services with varied points of entry into the system of care and provide wraparound services to those individuals who rely on us for that support. So as far as our ability to provide services effectively, it's critical that we partner in community. And partnering is not only critical to our success as an organization, it's critical to the success of our clients and those who depend on us. Partnering helps us maintain the continuum of service, It helps us enhance how we conduct case management and care coordination. And most importantly, it complements the CCDHC model perfectly. Some of the key partners with whom we work, including acute care, our hospital partners, primary care, our community-based health centers and rural health clinics, private providers, state agencies, law enforcement, criminal justice, as well as other community stakeholders like those of you here in the audience today with Nothing Montana. So the topic at hand is, what is a certified community behavioral health clinic? If I could boil it down to three key ideas, it's enhancing access to comprehensive community-based behavioral services with a sustainable funding mechanism. And that's been such a challenge for providers in Montana for decades. The fact that the funding wasn't there. So even in circumstances where we knew we could do better, we didn't have the financial ability to do so. And I think that is one of the issues that's resolved through this model.
Levi, would you just say that definition one more time about CCDHC?
So I would say enhancing access to comprehensive community-based services with a sustainable funding model.
Thank you.
What you see here is a little bit busy on the slide, but these are the 9 core services that are required to be certified as a CCDHC. This is established at the national level by the Substance Abuse and Mental Health Services Administration. So I'll go through this, but I also want to make sure you realize this is not an exhaustive list of services that can be provided. This is the requirement of what has to be provided. So we're talking about crisis mental health services, including 24-hour mobile crisis intervention and support teams, emergency crisis intervention services like emergency mental health assessments, and crisis stabilization, a place for those individuals to go and receive help and treatment when they need to de-escalate and be stabilized. The model requires screening, assessment, and diagnosis, including risk assessments. The model requires patient-centered treatment planning, including risk assessment and crisis planning. So this is another subtle difference in how behavioral health has historically been provided in the state of Montana versus what we're striving for with improvement in this model. The idea that we're putting our clients at the center of all of our resources and working collaboratively to make sure that they receive all the care they need in their recovery journey. Outpatient clinic primary care screening and monitoring of key health indicators and health risk. This is a new introduction into behavioral health in Montana, the idea that we are integrating primary care screening. And further in the presentation, I'll give you a couple examples of what that looks like. But the idea that we need to have an understanding of an individual's physical health so that we can better treat their mental health is a critical change. It seems really simplistic when you think about it, but operationally, that's a major shift in how we function as an organization. We are required to offer case management, psychiatric rehab, peer support and counseling services. This is a huge opportunity for behavioral health in Montana to better utilize peer supports across all of our programming. And that's something that's encouraged and required by this model. And then finally, community-based mental health care for members of the armed forces and veterans. This is a very specific requirement and one that I think is extremely important in our state. This is something that I'm proud to be engaged in a program that identifies this need and works to specifically help this population. When we talk about enhancing access, I borrowed this graphic from the National Council for Mental Wellbeing because this really demonstrates what we're striving for and what other CCDHCs in Montana will be striving for. The idea that we know that our clients need support when they show up at our door or when we call. It does no good for us to schedule them for an appointment 30 days, 60 days, 90 days from when that call comes in. So a major goal of this model is to improve access to services and create timely access. So on this chart, the large orange on the side, that's 50% of the volume that's been measured by the National Council for Mental Wellbeing is same-day access, meaning that 50% of all interactions, those individuals are receiving the care they need the day they need it. They're not being scheduled for weeks down the line. But even if you look at the chart at large, only 2% of all recorded interactions, all reported encounters in care are exceeding 1 month from the time that care is required. And this is across the entire United States. Hundreds of thousands of individuals receiving hundreds of thousands of interventions and instances of care. Only 2% extend beyond a month from when they need it. A requirement of the grant program is also that we do not exceed 10 days. So again, think about our average community private practice when they can be scheduled out months and months in advance. It is now our requirement, it's our goal to ensure that those individuals get the care they need within the first 10 days from the time they present. And that's a major, major shift for organizations like us. So what has made this possible? In the state of Montana, we were fortunate to benefit from a number of grant cycles, but I do want to take a minute to explain what the original demonstration project was. It started in 2016 when 8 states in the U.S. were chosen to be demonstration states by the Substance Abuse and Mental Health Service Administration and provided funding so they could test out this model of care. That was the original demonstration project. And the results from that project, the outcomes, the improvement in access, all of the goals of this, those results were so striking and so important that SAMHSA immediately moved to expand the model of care and issue hundreds of expansion grants across the United States. So the expansion grants did not allow individual organizations to opt into the original demonstration project with enhanced funding, but they did allow us to benefit from funding from SAMHSA so that we could pursue this model of care on our own. Additional data over the last couple of years continues to demonstrate outstanding outcomes, improvements in access to services, and SAMHSA saw that and they said, okay, we have to figure out how to keep this going. So they did last year release a subsequent round of SAMHSA grants, and Western Montana Mental Health Center has been fortunate to receive and be awarded a number of grants to help facilitate our transition into this model of care. Many Rivers Whole Health, who's also here, was awarded a grant to help facilitate the transition into this model of care as well. The most recent round of grants, it has changed a little bit, and it puts it in a position to think a little bit more strategically about long-term and how we can be effective in providing all of these requirements, meeting all of these requirements over a much longer term. The original grants were 2 years, and now this most recent round are 4-year commitments. So you can see the intent of SAMHSA is to ensure long-term success in this model of care. All in, I think SAMHSA has dedicated in excess of $2 billion across the United States to facilitate a transition to this model of care. And if you put it in the context of primary care, back in the 60s, the federal government understood that we needed to do more with primary care and preventive care. And that's what they did with the community health clinic model for primary care. Now it's commonly referred to here in Montana as the federally qualified health center system. It was a very similar transition when the need was recognized, and now we're working through that same process with behavioral health. So this graphic that you can see, it's probably not as clear as I'd like it to be, but what it shows you is the original 8 demonstration project states, which include Oregon, Nevada, Oklahoma, Missouri, Minnesota, Kentucky, Pennsylvania, and New York. The But then after that, you can see all of the additional expansion states joined in because of the benefits that are achieved by this model of care. So today, there are over 500 CCBHCs across the United States. Here in Montana, we're lucky to have 3 organizations participating and converting into this model of care. Some of the states that you see on here have seen such great results that they took it upon themselves to implement the payment system, the sustainable payment system, outside of CMS, outside of the Centers for Medicare and Medicaid Services. A state like Texas has implemented CCBHCs, and they're projecting a $10 billion savings in healthcare costs by 2030 because of the implementation of this program. They recognize that if we're more successful, if we're helping our clients be stable in the community and receive the care that they need, then there's less interaction with law enforcement, there's less need for emergency department presentation, and an overall cost savings within the system of care. An additional significant point about this model of care is the requirement to measure outcomes. That sounds really simple, but I can tell you historically in the United States and in Montana, there was not a lot of collection of measurable outcomes. We provided a lot of services, and we measured volume. We could tell you how many people our therapists saw, but we couldn't tell you what the result was. And now, for the first time, we're measuring outcomes. We're looking at clinical programming and understanding the work that we're doing is affecting change, is helping people in a measurable way. The 3 areas of required data collection include the encounter-based data, like you'd expect, but also the clinical outcomes information, as well as quality information. What evidence-based practices are we using? What is the level of fidelity that we're providing within those evidence-based practices? Are we providing that care in alignment with those evidence-based practices? So I wanted to give you a couple of examples of the type of data that we collect, and those data demonstrated positive outcomes for our clients. So what you see here is a very simple primary care screening for blood pressure. This is something now that we collect on all clients who are enrolled into our certified community behavioral health clinic. This is aggregate data for 260 clients that were enrolled originally with baseline information and then reassessed at 6 months. And so something as simple as systolic blood pressure, you can see on average over 260 clients, we were above what would be deemed as a potential risk. People had high blood pressure. So then the question becomes, what do we need to do to help them and help coach them into a more healthy physical state that will ultimately help their mental health? And what you see here is after 6 months, we're on the left side, we're progressing from left to right. We have the green triangle here is what the average was on 260 clients. The 130 mark, the orange dash, is a level above which demonstrates risk for high blood pressure. And over 6 months, we were able to bring that aggregate average blood pressure for systolic measurement down below the risk level. So that's a result of, number one, being able to measure it. Actually having nurses in our clinics who are taking those measurements, understanding how we can help the physical health of our clients, and then working in a different system that encourages us to coach and work with our clients to understand what behaviors they may have contributing to high blood pressure and how do we modify that. So in a very simplistic way, we're able to make significant substantive physical health changes with our client population. Here's another example of the type of information that we collect. You may have heard or you may be aware that frequently we want to think about individuals who are experiencing mental health emergencies or individuals that might be having what's called a troubled night. So So we measure that. We ask clients when we enroll them into this program within the last 30 days, how many nights would you have considered your state to have been troubled? That could be nights spent homeless, nights in the hospital, nights in detox, nights in jail. Those are all contributors to what we refer to as troubled nights. And you can see, even though this is a very small number of people, if we focus on working with them to understand what their needs are outside of the outpatient therapy at home or some other traditional clinical intervention, if we work with them in community, we can make a drastic difference in their overall health and how many nights that they feel that they've been troubled. We see over a 6-month period with 25, if I'm adding correctly, 25 people, a reduction of 227 troubled nights, just by working with those individuals over a 6-month period. That's a huge impact. And that's because of what we're allowed to do and able to do with enhanced funding through the CCDHC model. Then finally, this is the last piece of data that I have, but I thought it was important to share. One of our biggest challenges, especially those individuals who are suffering from a severe and disabling mental illness, is to help them show up for the appointment. Transportation is a huge problem. Making sure that we're doing everything we can to encourage them to get them to the appointment so they can receive the care they need. That's a big challenge. And when we started with this grant, we set a goal of having a show rate of 80% for all appointments we schedule. We wanted the client to show up for no less than 80% of those. And what you see on this chart is a 1-quarter measurement. So in 1 quarter for enrolled clients, we had a total of 6,422 appointments scheduled. And on this particular chart, we were able to achieve a 90% show rate. So very simple things in how we work with our clients, how we coordinate care, how we ensure that they gain access to services, has made a significant impact. And the quarter after this, you're probably not able to read the bottom, but we made an additional improvement. So in the first quarter of year 2, we had a 90% show rate. In the second quarter of year 2, we had a 91% show rate. That speaks to improving access. And that speaks to our ability through this model of care to do a better job for our clients. And that was our goal from the outset. I think that's my last slide.
Yes.
I'll pass it over to Gary. Through this model of care to do a better job for the clients. And
You're up.
Good morning, everyone. I'm Mary Windecker with the Behavioral Health Alliance. I'm thrilled to be here today and thrilled to see such a crowded room. NAMI is such a great organization, and I work at home. I'm the only employee of the Behavioral Health Alliance, and my office is in the basement. So I love to get invited to places like this where I actually get to be around people, especially consumer advocates, because you are why we do everything we do. And it's so great to be reminded of that and be out among the people who we do everything for. I always have to be reminded because, like I said, I work in the basement and my cat comes down once a day to see me, and otherwise I'm pretty isolated. So Levi and I are tag teaming. What he was talking about is the SAMHSA grant funded CCBHCs. So how many of you have heard of CCBHCs before today? Okay, well, it's kind of become the buzzword around the state, CCBHCs, and like with any buzzword, no one really knows what it means. And so we're going to play a little game today, true or false. And it doesn't matter if you don't really know, there's no prizes being given out. I just want you to shout out what you think as I ask these questions, because we are going to try and dispel the myths over the next couple of months around CCBHCs. So you're my focus group on what people believe, so we can start correcting it with frequently asked questions and doing a lot of work, putting out some posters, really getting some facts around it with the National Council so people know what it is. So you want to go to the first slide, Levi? So the first question, true or false? CCBHCs will replace mental health centers in Montana. True or false? One true, mostly false. Okay, Levi? False. CCBHCs are a new financing model in providing health care. So when Levi talks about it being sustainable, what it does is really put mental health and substance use disorder treatment on a level playing field with primary care. For the first time in Montana ever. The treatment would be paid in a similar way as medical health care. And that's why we would be allowed to treat people in a much more effective way. But certification is a goal that any provider could achieve, and the state could see fit to make them one. I'm going to talk more about the demonstration project that the state is going to go for. Just as community health centers did not get rid of primary care providers, CCBHCs would not get rid of mental health centers. Mental health centers would still be there. Some of them would convert to CCBHC centers. So that's really the correction around this. They would not replace all mental health centers. So the mental health center you work with may or may not become a CCBHC, may just continue on the way it is. So it's just a new funding model, and some of the clinics would become CCBHCs, just like some clinics became community health centers back in the 80s and 90s in Montana. Okay, next one, Levi. True or false? All CCBHCs offer the same services. Okay, pretty evenly divided there. I'd have you a leg wrestle for it, but I don't know if we have the time. So Levi, show us the answer. False. While CCBHCs must provide the same baseline services, which Levi showed you in his slides, the state, in partnership with the clinics, will conduct needs assessments of each region. So the clinics and the people in the region will decide what services need to be offered. So it's not a one-size-fits-all model. If you already have a crisis response team that is providing those services, they can partner with the CCBHC. The CCBHC does not need to duplicate those services and create more cost to the county and state. If you don't have a crisis response team that is providing services, the CCBHCs will have to stand up those services. So each county will look at what's already, or each region will look at what's already available, take advantage of what's already there, not duplicate services, partner with those that are already there, and fill in the blanks for what's not there. So it's a very efficient model, not just building a whole new clinic and competing with what's already there. Next one, Levi. True or false? Any organization can become a CCBHC. I heard one true and a couple truths. Okay, Levi? False. There's no prizes, people. CCBHC has strict governance rules. So it has to be a nonprofit organization. It can be part of a local government behavioral health authority. So for example, a county could create a CCBHC. It can be an entity under the IHS, Indian tribe or a tribal organization, or it can be an Indian, urban Indian organization. A for-profit organization can be a designated contracting organization, but it can't be the CCBHC background or backbone organization. So there's one state where a methadone clinic became a CCBHC. I'm not suggesting that for Montana, but I'm just letting you know that there are a number of different organizations. It's not just mental health centers. It's not just FQHCs. If a community health center, federally qualified health center, decides to become a CCBHC, they have to get a new provider number and basically open a new clinic, not a bricks and mortar clinic, but they'd have to open a completely new 24/7 mental health center basically to serve as the background organization. So there's a lot of options out there for who can become a CCBHC. So it's not limited to just mental health centers. So in some of the rural areas where you maybe don't have a mental health center, there's an opportunity that, you know, your critical access hospital or your, if it's a nonprofit, or your community health center or one of those could become the CCBHC, your county organization, your county health department, that kind of thing. Okay, Levi?
So Mary, just one sec. When you talk about, can you go back for just a sec? Levi? Give us an example. Would it be like the county health department that would be part of a local government behavioral health authority?
Correct.
That's what you're talking. What else other than a county health department? Or is that really what it is?
Well, community health center, in many places, the community health center is part of the county, so that would be considered your behavioral health authority. I can get other examples for you from other states that have stood up. Only about 10% of all the CCBHCs across the nation are actually federally qualified health centers. For the most part, federally qualified health centers, they're open Monday through Friday, 8 to 5. They're not open holidays. You know, for them to take on a whole new clientele, a whole new range of services, be open or be available for crisis 24/7, be open weekends, holidays, all the things that are required. It's a whole new service line. It's a lot of work. Not all the FQHCs were interested in doing it. So, you know, that's why you found them partnering with CCBHCs to provide the medical primary care piece as a designated contracting organization, but not necessarily doing all the hard work of being a CCBHC. So it's a lot of work.
Thank you.
Does that answer your question?
It does, thanks.
True or false? A CCBHC is just like a community health center or federally qualified health center, but for mental health. Okay, one true and a bunch of falses. Levi? False. Well, payment structures are similar, so that we're creating a level playing field between medical and mental health. They're not the same, but services are different. And flexibilities are more aligned with the needs of the behavioral health care. That was written by the National Council, and I think it's very confusing. But what they're saying is that where federally qualified health centers tend to be a building, and you go to this building to get your services, CCBHCs tend to be more out in the community serving you. So they may have your PAC team, and they're out in the community working with people on the ground, meeting them where they are. They all have peer supports. You know, peers are out in the community working with people where they are. It's not a big fancy building where you come to them. They're gonna be out in the community working with people where they are. Housing tenancy, a lot of the things we talked about yesterday. And the advantage of the funding model is that it's bundled, so they can provide a lot of these services that have never been available in the mental health centers before. Well, I just talked about that, so I guess I explained it anyway. Does that make sense? It's an exciting model. I've been working on this for 3 years, and just really, as we vetted the models and we looked at it, it was the most exciting model I saw. I had the advantage of being in the federally qualified community health center, partnership health center in Missoula when it was first starting up in the mid-90s. And it was when we were in a tiny corner of the health department up on the second floor. We didn't need to email because we could just shout across the desk at each other. And there were like 10 of us, and we were so passionate about what we were doing, and it was so exciting. And the community was just like with CCBHCs. The community was like, what are these people doing up there? You know, this doesn't sound like a good idea. They're going to compete with the doctors. They're going to compete with the hospital. And here now, all these years later, you can't imagine having a community without a community health center. It's where people go to get their primary care, get their immunizations, get everything they need, raise their kids, have their whole child checks. So it's how I see CCBHCs now. It's the same kind of excitement to move forward. Okay, I think this is the last true or false. CCBHCs have been proven to provide more access in rural and frontier areas. Okay, you guys are catching on. That's a true. We probably can't read this. All of these slides will be available on our website, but yes, this is a example from Oklahoma, rural Oklahoma. It was one of the first demonstration projects. So inpatient hospitalizations dropped from 2015 to 2021, 98.1%. Inpatient hospitalizations. From 2015, or is it 16? I can't see. 16 to 2021, decreases in inpatient hospitalizations saved more than $62 billion for the state of Oklahoma. The number of adult clients served increased by 163.5%, from 4,300 to 11,400. So that's what we're talking about, access to care. Saying you have a serious mental illness, we can see you in 2 months, is not access to care. You might be suicidal, we can see you in 3 months, that is not access to care. So we've got to get this new model where you can be seen when you need to be seen. And then law enforcement in 7 counties, rural counties, saved 576 days in time spent transporting patients. The dollar cost with that was $718,000 saved. So that law enforcement is not driving somebody from Glasgow to Deer Lodge or Warm Springs. You know, it's just, and then, you know, the person is so far from home. They can be treated close to home, close to their family, and then released back into the community where they'll have support instead of turf. Okay, next, Levi. I think that was my last true and false. So I wanted to give you a side-by-side comparison of the 2 funding models. I don't think we could have confused the feds, not we, but I don't think the feds could have confused everybody on the CCBHC model more than they could. So there was the SAMHSA funding, which is what Levi was talking about, and those were grants that were 2 to 4 years and sunset. Those do not create CCBHCs. They create the ability for organizations like Western Montana Mental Health Center and Center for Mental Health, Rimrock, Eastern Montana Mental Health Center just received a grant to put in place the things they'll need to when the state certifies for certified community behavioral health centers. So they're grants that help agencies prepare for this model. The left side of the screen is kind of what the state is looking at going for. So that's what comes with the enhanced reimbursement from CMS, similar to an FQHC. That's what we're working on coming forward in the next legislative session. Representative Carlson was on the interim committee that voted unanimously to move a bill forward into the 2023 legislature that requires DPHHS to move CCBHCs forward and implement them by 2024 or 2025, I can't remember. Yeah. But to have DPHHS move forward. I will say DPHHS is very excited about this model. BAM received a $75,000 grant from the Murdoch Charitable Trust over the last year, and what they did was hire the National Council to come in and show providers what this would take and make sure that they thought they could do it, and also to show state stakeholders, so the Hospital Association, NAMI Montana, the Montana Primary Care Association that runs community health centers. There were some payers in there, some insurance companies, Department of Corrections, tribal health leaders, a variety of different organizations, everybody we could think of, we pulled in, DPHHS, everybody from the state that we thought would be involved. And they went through 6 months of basically lessons in what a CCBHC would require, what would have to be done, how it would work, whether Montana could pull it off. And DPHHS got really excited about it. So they're very excited now to apply for one of the planning grants. So next slide, Levi. So this is the goals that Levi kind of talked about. This is what we're hoping the CCBHCs will do in Montana. Access to care, as you saw in Levi's slide, 50% same day access. That's huge. Reduction in hospital and ER usage. Some of our critical access hospitals are just getting inundated with people because there's no other services available in the rural counties. Follow-up after hospitalization. That's where I talk about somebody going into an acute hospitalization and then getting turfed back home without any support. What are the odds they're going to end up back in the hospital within a week or two? Pretty good. Engagement in substance use treatment. That's just huge. So much of the substance use disorder treatment, you can't separate it from mental health issues. You've got to treat both. And it just can't be, if a parent has a substance use disorder treatment, you've got to treat the whole family for the mental health issues that it's caused. You can't just throw the kid back into that after the parent's gone through substance use disorder and not expect that kid not to have suffered some mental health issues. You got to treat all this together as a unit in the community with the family. Otherwise, you're just going to keep a revolving door going. I'm preaching to the choir here, I know, but I just like to say it out loud quite often. Increased access to medication-assisted treatment for substance use treatment, so the various medications that people can take if they're going through substance use treatment, MAT, they call it, so medication-assisted treatment, and that's available now in hospitals, mental health centers, federally qualified health centers, community health centers, most treatment centers, that medication-assisted treatment is available, and it will be available in the CCBHCs as well. It will address behavioral health care workforce shortages simply by reimbursing providers the same way it reimburses medical care, so that we're allowed to pay people. The question yesterday, who determines how much they get paid? The reimbursement hasn't been raised for Medicaid. I think we got 1% in 2021. We had asked for 2%. Some programs have been raised over the years, but the new rate study that's going through has anywhere between a 10% and a 25% increase because we've been so low for so long. And people are just fleeing. We have 20 to 30% vacancies because you can't live in Montana on $12 to $15 an hour anywhere in Montana anymore. It's just not doable. And so we've got to get those rates up. Even in the fee-for-service model, that's what the rate study will address that's going through, and we're hoping that will be put forward in the governor's budget, and that the state will enact the governor's provider rate increase, because we worked very hard on that. But at the same time, we're working on the fee-for-service side that's in place now. We need to change the model and really do some transformative change, which is what this CCBHC side is. We need to raise it up so that it's on a level playing field finally with physical health. Why is mental health not paid at the same level as physical health? Question? Yep, Bob.
So, is on the payment model, is it like FQHCs in that you have a patient component that's built into it, and then also CPS type measures?
So, his question was, is it the same as an FQHC, whether it's paid on a UBS model? It's complicated. It's paid on a prospective payment system. So they calculate the cost, of the entire care. Similar to what they do for an FQHC, but there, for a community health center, it's prospective. For a CCBHC, it's retrospective, so it's the true cost of providing the care. DCO, designated contracting organizations, and everything, and then it's paid on that bundled system. So right now, if you go to your primary care provider at a community health center, they're paid, let's say, $150 for your 20-minute consult. That money covers the receptionist, the case manager, the pharmacist, the doctor's time, the nurse's time. It covers all of that. In behavioral health, you see a therapist, they only get paid for that 50-minute visit. There's no extra money. Maybe they get $75 for that 50-minute visit. There's no money to cover all of the cost of delivering that care. So when we say it's a reimbursement model similar to the community health centers, that's what we're talking about. It's a bundled rate that actually covers the cost of delivering the care so that the companies aren't going out of business delivering the care. Does that make sense? It's complicated. And then improved integration of care, this is where case management comes in. Case management has never been valued the way it should be. I mean, I think that anywhere in the healthcare system, I've worked in it for 30 years, it is the most confusing thing in the world. Everybody should have a patient navigator to help them every time they have to engage with the health system. I don't care what system they're in, whether it's hospital or anywhere, it is the most confusing thing in the world. When I have to go get medical treatment, I'm just looking at them like, what are you telling me to do? You know, you need that person. So case managers are hugely important. Care coordinators are hugely important. This model embeds the care coordinators into the system, pays for them to be there so that they can help patients navigate the system. It's even worse if you're in crisis. If somebody's in crisis or a family member's in crisis, trying to get to understand what's going to happen, that's where care coordination and case management comes in. So this model covers that piece of it, and it's such an important piece. Next one, Levi. So this is just an example of some of the new services that would be covered in the CCBHC. On the left side is some of the services. These are just examples that we talked about. And then it has to have evidence-based practices. And again, these are just some of the examples of evidence-based practices. They're required to use evidence-based practices, which is great. And then track outcomes, as Levi talked about, which for the first time would be really important in Montana. We started doing it, but it's super, super important to have those numbers to show that an agency is providing good care. And so these are some of the evidence-based practices that they would have as an example of what they would provide. Next slide, Levi, and that maybe, next steps for Montana. So last week, DPHHS announced that they are going to be conducting surveys of agencies that are interested in providing CCBHC care. So we're submitting a list of all of the providers who are interested in our organization in either being a CCBHC or a designated contracting organization. So for example, maybe there's a children's organization that provides only children's care. They're not really interested in providing the full continuum of care for a CCBHC, but they'd be very interested in working with an organization that's providing the CCBHC to provide children's services. It's what they do well. They don't want to branch out and do everything. They just want to provide children's services. So they would be a designated contracting organization. So that's where I talked about they keep doing what's doing well and doing what they're doing and doing it well instead of trying to be all things to all people. DPHHS can apply for one of the CMS grants. this fall. It just came out last week. There are 40 states eligible. 15 states will be chosen. And out of that, after 6 months or sometime next summer, the states will be chosen that will move, the 15 states will be chosen. They will receive a $1 million planning grant. For the next year, from the time they're chosen, they will engage in state planning to implement CCBHCs in the state. We are hoping like heck that Montana is in that first round. If Montana isn't in that first round, we have to wait 2 years to apply for the next planning grant. So we're really pushing it. I'm calling in every marker with the senators, testers, and Danes, and I'm calling in, basically just pestering people mercilessly at National Council and anywhere else. And then the 2023 legislature must pass the bill that the interim committee put forward. It's going to be submitted to the full legislature, and they have to pass that because CMS and SAMHSA need to know that the state legislature is on board with this model. So they have to pass that bill. It has to move forward in this legislative session so that if they get the planning grant, all our ducks are in a row to move it forward. So what can you do? Last slide, Levi. Educate yourselves about CCBHCs. We're going to have up on our website this presentation plus talking points, all kinds of forward-facing information about CCBHCs, frequently asked questions. It'll all be under our advocacy page. We're going to just really try and take the mystery out of it and make it very simple how you can understand it and talk to your legislators about it. And then advocate to your legislators about CCBHCs. We'll have talking points for you so you can go and speak, or you can call your legislators. We don't know yet if they're going to do online testimony, or I don't think any of that has been decided. Has it, Representative Carlson? So if you have to go to the legislature, but you can always submit written comment. You don't have to travel to Helena. You can submit written comment to your legislator, you can call them up, you can email them, and advocate for a system, a model that puts mental health on a level playing field with medical health. It's as simple as that. So that's where we are. A question?
Tell them to start calling now.
Start calling now. From Representative Carlson. So true, everything is starting to plan and getting up. I will have the website updated. I'm working with my contract marketing guy, but there is just me. So be patient. This will be up Monday or Tuesday, this PowerPoint. And the rest of the information will be up in the next week or two. Okay, you, sir, in the back at the beard, you were first, and then I'll get to the rest of you.
Yes, my name is Rick Williamson, and I live down in Plains. This comment question is more for Levi.
Okay, come on up, Levi. I hope it's a hard one.
We'll see. I'm going to try to be as polite as possible. In 2013, I'm a retired vet, and I had to go through Senator Tester VA program called Veterans Choice, which was a contradiction in terms. But anyway, in order to get a therapist, it took me 3 years to get a therapist with Western Montana Mental Health. I finally got one, and it took me a while before I could trust her. I was with her for 5 years. And anyway, during the time that I was with this therapist, I became a peer support specialist. I am certified in the state of Montana. Last year, I went to the office in Thompson Falls, and I offered my services as a volunteer peer support specialist The people in that office looked at me like I was nuts. And I said, well, do you have peer support specialists? One of the ladies asked me what it was. And I explained it to her, and she had no clue. And I asked her, is there somebody in Western Montana mental health that I can contact? She said, well, I don't know, but here's the phone number. She gave me the phone number to the office in Missoula. I'm still waiting for the 3 phone calls back.
Really sorry to hear that you had that experience. But at the same time, as I mentioned in my presentation, providers like Western, we've not done a good job using peer support specialists throughout our program. And that's one of the things that we're really excited about with this model. There are certain programs that we operate that have peer supports embedded, like our assertive community treatment programs. But in those areas where we don't have a defined program like that, I acknowledge that we need to do a better job in using peer support services and really working with peers because we know the benefit. There's plenty of documentation, there are plenty of studies that demonstrate the significant benefit that peers can bring to client care, and we need to address that.
Matt's asked us to cut it off, but we're going to take a break, and we're happy to talk to you during the break if you have additional questions. Also, you can call either Levi or myself anytime. I'll put up during the break my email address, and this presentation, as I said, will be on this website, but you can email me, call me anytime, and I'll be happy to give you a call.